And next we'll hear from Dr. John Brooklyn, who's a board certified in family medicine and addiction medicine and assistant clinical professor on the UVMMC Family Medicine and Psychiatry faculty in Vermont.
Thank you. I stand here on the shoulders of giants, Alan Leshner, Dave Lewis, people that I looked up to 25 years ago, and thank you for being so kind to invite me. So let's see. I just wanted to put this slide up because I know you've all been sitting here all morning, and you probably haven't been seeing anything very beautiful except our ties, etc. So I thought looking at the leaves of Vermont for a moment may lift your spirits in this sort of dark and tough conversation we're having. But make no mistake, Vermont, and this is because Adam was there 2 weeks ago, I wanted to remind him of what it looked like. But the second thing, and Gavin will remember this slide when we were in Vietnam, I want to remind people where Vermont is, because many people don't realize that we're way, way up in the northern corner. But I think our experience in Vermont can be replicated around the country and around the world in terms of what we've done. So just as a reminder, we're a very socially active, progressive state, but also fiscally conservative. So the model of the hub and spoke is really predicated on a number of issues, including cost containment and great medical outcomes, which I'm going to share with you now. So this slide is worthy of note. In September 2017, no longer in the state of Vermont was there a waiting list. You could walk into any opiate treatment program in the state and get treatment on demand. There was access in most regions of the state to accessing buprenorphine treatment in an office-based setting. So basically the hub and spoke system integrates substance use disorder into primary care and provides office-based supports and a referral network for more complex cases. Does this sound like any other disorder we take care of in medicine? Because it is. We treat it just like any other disorder we take care of in medicine. People can start at a hub, which is an OTP, and go to a spoke, or they can start at a spoke and go to a hub if their need is greater. The key thing is that no one loses treatment because they have opiate dependence. We know many docs around the country get fearful about taking care of individuals who perhaps are diverting, using other substances, and we have a safety network so that people do not lose their treatment for the most part for any particular reason, and the main goal is to prevent overdose. This is a picture where the hubs are located in the state of Vermont, and I want to draw your attention to the upper my right-hand side of Vermont, which is very rural. There are about 5,000 people in the town of Newport, about 3,000 people in the town of St. Albans, and yet they, St. Johnsbury, but they have hubs there. They are OTPs that are located in extremely rural areas. So we believe that this model is replicable around the country because we've had it in rural locations and actually very populated locations. It's built on 6 core services from Section 2703 of the Affordable Care Act. All hubs and spokes are supposed to provide a level of service, one of these 6 here, in order to get certification. And all of our hubs are national NCQA approved for providing specialty care. Spokes are linked to a regional hub. All buprenorphine providers can be considered to be a spoke. The key thing about spokes is that many of them are community health centers, and I was talking to Judith earlier about the key model is predicated on multiple services occurring in one location. But the essence of the spoke success is the MAT team. This is a funded team at no cost to the practice with 1 FTE case manager and 1 RN per 100 buprenorphine patients. And these are individuals who come to the physician's office, either they're embedded or they travel, and they help the provider manage opiate use disorder with buprenorphine in the office. We also provide a learning collaborative because what we recognize is the 8-hour training is just an 8-hour training. And so we've had multiple iterations over the years of learning collaboratives. Every year we put on 4 to 6 sessions. We're about to have one this coming Friday on transitions of care, 6 hours looking at all the issues that come up from people transferring to hubs and spokes with the idea that it's addiction 2.0 and 3.0 so that people can get more experience. This is a slide to show you the distribution as of June 2018 of medications in the hub. We have a total of 3,700, about 3,639 people in the OTPs in the state, of which about 1,000 are on buprenorphine, 2,500 on methadone, 2 on extended release naltrexone, and 17 that weren't receiving treatment but not yet dosed. In other words, they came in for an intake but they hadn't been started yet, and 0 waiting list. This is a graph showing over time what happened as the waiting list disappeared, the number of people into treatment. This is a slide showing the number of spoke patients, providers, and staffing. And the reason I put this slide up here is this is a key piece of this. When you talk about increasing access to care, you have to talk about retention. And so what we did is we looked at all the numbers of providers in the state that had a waiver and how many were prescribing for under 10 individuals. And we targeted those individuals to get them at least to prescribe greater than 10. And as of June 2018, 70 out of 234 were prescribing for at least more than 10 people. The other slide here illustrates the same thing. We went from 114 waivered physicians in 2013 to 212 in 2017, and the number that were prescribing for greater than 10 went from 38 to 63. So what you really see is when you provide services to the physicians on the ground, the providers on the ground, they're willing and able to take more people, which translates to broader access, because you don't want to have one doc at 275 retire and have nobody that they can send patients to. If you have 30 docs all taking 10, when a flood occurs, it can be more easily absorbed. The other key thing I wanted to point out is that we have about 625,000 Vermonters, 80% over the age of 18. Currently, we have 7,365 people out of 500,000 on MAT. That represents 1.47% of the entire population in Vermont on MAT. When you look at your data that you presented today, you have some states that have less than 1/10% on MAT. So if the estimate is that 1% of the U.S. population needs MAT at 2.4 million people, and we've demonstrated 1.47 people, which is only perhaps half of what we need, how much are we underestimating the need for treatment? Do we really need 2 to 3% of the number of people who have opioid use disorder in treatment? So that's a workforce issue. This is a cost analysis where costs have gone down if you're in treatment. And we've also now have MAT in prisons. Anybody who's on methadone or buprenorphine remains, and anybody who's got opiate use disorder in prison is now being put on buprenorphine pending release. The other outcome is reduction in overdose deaths. I know I'm running out of time. I apologize. We have been stable in terms of the number of people who've unfortunately overdosed. 104 the last 3 years people have died. The fentanyl amount of percentage of that has gone up, but the fact that we've stabilized our overdose rates has a lot to do with access. Thank you.